Hello, you beautiful people. We are back here to study the treatment part of asthma with me, Dr. Achila. Now, first thing first, we will be discussing the topic, but also I want you people to write the facts or the things in your notebook that you are not aware of before and make robust notes of yours. So, let's log on. Coming to the treatment part of asthma. This box I have borrowed from the Harrison. It says the goals of asthma therapy. First, there should be reduction in symptom frequency to less than equal to 2 times per week. Second, reduction of nighttime awakenings to less than equal to 2 times per month. Reduction of reliever use to less than equal to 2 times a week except before exercise. Fourth, no more than 1 exacerbation per year. Fifth, optimization of lung function. Sixth, maintenance of normal daily activities. Seventh, satisfaction with the asthma care with minimal or no side effects of treatment. So, of course, the triggers that we have studied in earlier video. So, these are accounting to the exacerbation of asthma. So, the removal of the offending agent or trigger is very important. Next is the allergen immunotherapy. So, how does it work? It reduces the Ig mediated reaction to allergens. So, the guidelines say use of immunotherapy should be made only in the patient whose asthma is under control or who has mild to moderate asthma. Bronchodilators. Now, what is the role of a bronchodilator? So, it relaxes the airway smooth muscle. Beta 2 agonist. Now, the beta 2 agonist, how does it help? These have the beta receptors. Beta receptors are G protein coupled receptors. They are present on the airway smooth muscle. They activate the adrenaline cyclase and produce cyclic AMP that causes smooth muscle relaxation. Now, the regular use of beta 2 agonist causes tachyphylaxis, which increases the airway reactivity. Increase in use of short acting beta 2 agonist increases the asthma mortality, which we have seen in the earlier video. So, what are the beta 2 agonists? So, these are short acting, long acting, and ultra long acting. In the short acting, we have albuterol, salbutamol. So, these are the most commonly used. The bronchodilation begins 3 to 5 minutes of inhalation and which lasts for 4 to 6 hours. So, this can be a potential MCQ. Then we have a salmeterol or formoterol, which is a long acting. Now, also we have to remember here that the formoterol has a quick action. So, these both can be used in COPD as well, used with inhaled corticosteroids and not as a monotherapy. Then we have indacaterol or we have vilanterol. This is a ultra long acting. So, the side effects include tremors, palpitation, tachycardia, QT prolongation, hyperglycemia, hyperkalemia, or hypokalemia. Now, this hyperkalemia is seen at low doses and hypokalemia is seen at high doses. Also, lactic acidosis is seen, which is due to glycogenolysis, glycolysis, and lipolysis. Then the next class is the anticholinergics. In the anticholinergics, we have ipratropium and tiotropium. Now, the drug of choice is tiotropium. Anticholinergics are mostly used in COPD. The ipratropium is a short acting. The side effects of anticholinergics include dryness of mouth, glaucoma, and urine retention. Then we have methylxanthines. Now, this methylxanthines have the theophylline or we have the aminophylline. They act on the phosphodiesterase 3, 4 and adenosine receptors. We should remember that the theophylline has a narrow therapeutic index. What are the side effects? The phosphodiesterase 4 inhibitor causes vasodilation, hypotension, nausea, vomiting, and headache. What are the side effects of adenosine receptor? They include seizures, arrhythmia, and diuresis. Now, there is something which is a controller. Now, controller is a name which is given to the corticosteroids. So, remember by CC, right? They reduce the asthma exacerbation, improve long-term control, decreases the need for intermittent use of bronchodilator therapies. So, actually, they reduce the type 2 inflammation and airway hyperresponsiveness. The steroids bind to the cytoplasmic glucocorticoid receptor and then they make a complex which translocates in the nucleus. This complex binds to positive and negative elements which causes inhibition of T cell activation and eosinophilic function, migration, proliferation. They also attach to the other transcription factors resulting in deactivation of other pro-inflammatory pathways. So the greatest combination is with of inhaled corticosteroids and long-acting beta-2 agonist. So the longer acting preparations can be used once a day, and for persistent asthma, a twice a day regimen may be used. Oral corticosteroids. These are only and only used when the inhaled corticosteroids are not effective. And this is because of their systemic side effects. So for that, we have the prednisolone that can be used on alternate day dosing. We have something which is called a pneumocystis pneumonia. So the pneumocystis pneumonia prophylaxis need to be given when the prednisolone dose exceeds more than equal to 20 milligram. This is because of immunosuppressive action of corticosteroids. For asthma exacerbation, 40 to 60 milligram per day of prednisolone has to be used. The side effects of corticosteroids include diabetes, osteoporosis, cataract, glaucoma, bruising, weight gain, obesity, hypertension, depression, ulcers, oral thrush, and hoarseness. What is intermittent burst? To reduce the side effects of systemic corticosteroids, these corticosteroids can be used intermittently and not on the daily basis. The next class includes the leukotriene modifiers. They include LOX inhibitor and cysteine LT1 antagonist, LTB4, LTC4 inhibitors. Now this LOX inhibitor is the Xileutin and the LTB4, LTC4 is the montelukast which we all use, and there is this zafirlukast. The montelukast and zafirlukast are used in Churg-Strauss syndrome. The montelukast is most used in children with mild asthma. The side effect includes depression and suicidal ideation that we are not aware of. Significant leukotriene production occurs mostly in aspirin-induced asthma. The cysteine LT1 antagonist is a rapid action antagonist and has a chronic effect that is lasting for 1 month. Now, zilutin is a LOX inhibitor which increases the liver function test and inhibits CYP1A2. The next class includes the mast cell modifiers. They include cromolyn sodium that only act through inhalational route. The mast cell stabilizers, if they are not activated, then there is no activation of eosinophils and basophils, and in turn there is no inflammatory reaction. So mostly used in children. Then the anti-IgE, that is the immunotherapy. This omalizumab. Now, what is omalizumab and how does it work? It is a monoclonal antibody. Now, this omalizumab binds to the Fc portion of IgE. It prevents the binding of IgE to the mast cells and basophils, blocks antigen-related signaling, which is responsible for production or release of many mediators or cytokine. Now, this anti-IgE increases the interferon production in rhinovirus infection, decreases the viral-induced asthma exacerbation, decreases the duration and peak of virus shedding. Now, this anti-IgE test can be seen as a positive test if the Ig levels are more than equal to 30 international units per ml with a positive skin test. So, this anti-Ig levels or the antibodies that are used decreases the exacerbation by 25 to 50%. It decreases the asthma symptoms but has a minimal effect on lung function. Anti-Ig are given in a dose which is formulated according to the weight and the levels of Ig. Mostly given subcutaneous every 2 to 4 weeks. The maximum dose is the 300 mg every 2 weeks. Now, the maximum effect is seen whenever the exhaled nitric oxide is more than 20 ppb or the circulating eosinophils are more than equal to 260 microliter per microliter. Omalizumab is not used in atopic dermatitis. The next include the interleukin 5 inhibitor, that is the mepolizumab and the racemozumab, and interleukin 5 receptor inhibitor, that is the benralizumab. Now, they rapidly decrease the circulating eosinophils. These are effective only when the eosinophil count is more than 300. Mepolizumab and benralizumab are approved for home administration. The interleukin 4 inhibitor is the dupilumab. Now, this is recommended for home administration. It decreases the exacerbation by 50%. It is used in atopic dermatitis. So, remember D for D. Causes paradoxical increase in eosinophils. The exhaled NO should be more than 20 to 25 ppb. It is used in poorly controlled patient on moderate to high dose of inhaled corticosteroids or long-acting beta agonist. Now, the recent studies say there are certain bronchial thermoplasty procedures that are using radiofrequency ablation of airway smooth muscle cell. Then there are CRTH2 receptors and magnesium sulfate. So, this is the table directly from Harrison. So, according to it, there are certain steps, step 1, step 2, step 3, step 4, step 5, step 6. Starting from the lowest dose to the highest of them. So if the patient has only mild symptoms or only occasional asthma symptoms, then there can be no prophylaxis given or no usage of inhaled corticosteroids. So none, right? Prefer regular therapy. Alternative regular therapy is also not required. As needed, like a relieving therapy. So inhale corticosteroids or the formoterol in a very low dose or a short acting beta 2 agonist can be used. Step 2. Now this can involve low dose of inhaled corticosteroids and an alternative therapy of leukotriene receptor antagonist. The needed reliever therapy includes inhaled corticosteroids and the formoterol, which is a long-acting beta-2 agonist. In a low dose, of course. Then the step 3. The preferred regular therapy includes low dose of inhaled corticosteroid or a formoterol. The alternative regular therapy include a medium dose of inhaled corticosteroid, and the adjuvant therapy includes long-acting muscarinic antagonist. And of course, the reliever therapy is the inhaled corticosteroids and formoterol. So the inhaled corticosteroids in a low dose with the long-acting beta-2 agonist is the reliever therapy most of the time, and it is the great combination. Then we have the step 4, which is using a medium dose inhaled corticosteroids. The alternative regular therapy includes the high dose inhaled corticosteroids. Step 5 includes medium to high dose of inhaled corticosteroids or a long-acting beta-2 agonist with an add-on of LAMA, that is a long-acting muscarinic antagonist. Along with it, the anti-IgE, or we have the anti-interleukin 5 receptor or antagonist directly, or interleukin 4 receptor. Step 6 directly involves the immunotherapy. So what is the protocol? Now, to start with, we start with a beta-2 agonist in mild to moderate case. So on an hourly basis, we can give a beta-2 agonist. If it is not controlled, so take it a case of urgent care setting. Nebulization to be given every 20 minutes. Now, nebulization may include Duolin, Budecort, ipratropium, depending upon the patient's condition. So if the patient has certain cardiac symptoms or is a patient of IHT, so we need to avoid Duolin. If fail to respond in 1 to 2 hours, then the intravenous corticosteroids can be administered along with the oxygen supplementation, with or without magnesium sulfate or a leukotriene receptor antagonist, with or without the nebulized anticholinergics. So if the PFR is less than 60% with tachypnea and tachycardia, hospital admission is must. Now, there is a study, if the helium oxygen mixtures are used, it causes a decrease in the work of breathing. Antibiotics to be only administered if signs of infection. In asthma, there is hypocapnia, so it causes increase in respiratory rate. So if we are administrating someone who has this exacerbation and is having tachypnea, tachycardia, is sweating and needs an NIV support or a mechanical ventilation, invasive one, then our aim should be to increase the respiratory or to decrease the respiratory rate to decrease the peak airway pressure, which is achieved by a permissive hypercapnia. Now, this is allowing the PCO2 to increase, as already in asthma we have hypocapnia. So, there should be aim to increase the PCO2 and intravenous fluid administration, of course, which increases the pH and corrects the acidosis. Now, in pregnancy, usual pharmacology drug to be administered, but PG2 alpha to be avoided, causing bronchoconstriction. Aspirin exacerbated respiratory disease. There is overproduction of leukotrienes due to inhibition of cyclooxygenase, secondary to inhibition of PGE2. Now, here the patient should obviously avoid NSAIDs and aspirin. So, whenever there is overproduction of leukotrienes, so we need to use a leukotriene modifier. What is severe asthma? Severe asthma is something which is having undergone an appropriate evaluation for comorbidities and mimics education and trigger mitigation, remains uncontrolled on step-by therapy. So this was for asthma. Let's continue with some other topic. Thank you.